we were going to record it. But interrupt us with questions as we go along, okay? We'll make our way through this. So let me share my slides here. All right, can everyone see it okay?
Yep.
All right, fantastic. So as Muge said, I'm Cari Roestel, and I'm joined by Jean Davis, my fellow ambassador for Learn the Science Act Early from the CDC. We are ambassadors, but in this role, we do not receive financial compensation, and we have no other disclosures for our talk today. Today, we will be talking about how we can support you in your early identification of children with developmental disabilities in your practice. We want to help explain some of the recent revisions that were done in the Learn the Science Act Early program. Help all of you understand how parent education and engagement can help support developmental monitoring, surveillance, and identifying children as early as possible who may need that extra boost in their development. And we'd like to talk a little bit about some of the early interventions, supports, and resources that are available to kids here in Illinois. So just by way of introduction, the Learn the Science Act Early program was started in 2004 as a joint project between the AAP and the CDC with the mission to identify children as early as possible who needed that extra help, that extra boost in their development. They do this mostly via a lot of parent-facing educational materials that are distributed through different early childhood system partners, including pediatricians, WIC, Early Head Start, home visiting programs, in an effort to identify kids as early as possible and get them into the services that they need. So it's really important for everyone to know that 1 in 6 kids in the United States has a developmental delay that would benefit from early intervention support. In lower socioeconomic households, that number jumps to 1 in 5. So it's very common. However, right now we are identifying these kids, generally only about half of them before their 3rd birthday. Identification before the 3rd birthday is super important because children's brains are growing most rapidly. They're most neuroplastic before the age of 3. And so therefore, any intervention that we can do pre-3 has lifelong positive, exponentially positive impacts. So we really want to just redouble our efforts to find kids as early as possible. Similarly, our most recent numbers from our 2020 data shows that 1 in 36 8-year-old kids in the CDC's surveillance network for autism has autism spectrum disorder. So it's also very, very common. And also we have a lot of research that shows that autism diagnosis is very reliable at 24 months. So this is another area that we're looking to find more kids as early as possible. Most children are not identified or diagnosed before the age of 4 in this country, and we really want to move that needle lower. So whatever we can do to help find these kiddos, get them into services before 3, that's really what we want to focus in on. So the CDC views early identification as a 4-step process. The first step is educating parents about what expected development looks like. So as I mentioned, they do a lot of parent outreach and education. This is helping parents notice how their child is developing in all 5 areas of development, as well as giving them information about how they can best promote their child's optimal development. So the second step is what I think most of us think about when we think about early identification, and that's the physician using a validated tool like the ASQ, the MChat to do that developmental screening, check in with the parents, use a systematic tool, if you will, to look, see how a child's developing and determine whether or not that child needs to be referred for further evaluation and intervention. Step 3 is a referral for services, and step 4 is the actual receiving of those services. So it's a 4-step process and a 4-step bridge, and we see kids fall off at each point along this bridge. So we're hoping to really get information out to physicians to help them support families from each of these steps and finally get to that final step of actually receiving the services. So we'll talk a little bit more about how you can support them receiving services at the end of the presentation. So the CDC's Learn the Signs program really focuses on that first step, that parent engaged monitoring. And they do that by creating a lot of family-facing educational tools centered around developmental milestones. So the developmental milestones are really the core of all of their, all of the media, all the educational materials. And they're really encouraging parents to track their child's development with these milestones. So we have a couple of examples here of what that media looks like. In the center, you see the checklist. There is a checklist that is available to print off the website for every well child visit age. So you have one that lines up with each age. On the right, you see the Milestones Moment booklet, which is a collection of all the checklists together in one. And on the left, we have the app. It's the Milestone Tracker app, available in Spanish and English. And this has all the checklists on it. It has videos and pictures of what each milestone looks like as you attain it. And also it sends parents prompts like, hey, do this to promote your child's development. And especially important, it sends reminders to make those well child visits at each age. So it really helps get kids to the doctor at each appointment time. Hold on, not advancing. There we go. So the AAP did issue a recent set of recommendations, a clinical report in 2020, and here's the link to that here so you can refer to it. One of the biggest takeaways we want everyone to be aware of is that research does show that using a systematic screening process, doing those ASQs at 9, 18, and 30 months, doing the MCHAT at 18 and 24 months to screen for autism, or whatever your preferred screener is, really does result in more children being identified at an earlier age than just physician judgment alone. So it is really important to go through the process of actually taking these tools out and going through the questions. More children are identified. But even more children are identified when we combine that parent education and engagement with the physician screening. So a 2018 study found that when parents know more and learned more about expected development, actually twice as many children were correctly identified to get early intervention services. So really, this is our dream team, and we really want to focus on helping parents learn more about development and how to advocate for their child and get them the services that they need. As I mentioned, all of the media facing the parents and the program is really centered around developmental milestones. And we're going to do a little deeper dive to talk about the CDC milestones because they are different than most of the other traditional milestones that you know about, the what to expect when you're expecting, or the baby center pathways, whichever milestones you might be more familiar with. And this is a result of a recent revision that was done to the Learn the Signs Act Early milestones in 2022. Before we jump into this conversation, I do want to just put a couple of reminders at top of everyone's mind that the CDC milestones are communication tools for you as a physician to talk to families about expected development. It can be a tricky conversation, and this offers you a structured way to have those conversations. These are also educational tools for families. They are 100% evidence-based, but they are not screening tools. They're not a validated screener, and they are not CDC standards or guidance. So in 2022, the new Learn the Signs Act Early Milestones were published, and you can read all about that here in this pediatrics article. We have it linked here. It was the result of a multi-year process of revisions that were done. The milestones were reviewed based on a number of things. One, the CDC was really looking to make sure that what we were putting out to families was evidence-based. And they really wanted to make sure that there was evidence behind all of these the developmental milestones. They wanted to make it simple and easy to use, and they wanted to improve the ability to use milestones as an early identification tool. So the previous version of the milestones from the CDC, and what most that you'll see are kind of vague, and you never know, like, well, is it okay that they're missing some? And our previous iteration had some red flags, but like, how many warning signs and red flags could you miss? So the goal here was to streamline them, make them easy to use as an early identification tool. So the two biggest changes that happened were they moved the age of attainment for the milestones that we have from an average age of attainment or traditional age of attainment to when 75% or more of children can do that specific milestone. So most milestones, the ones that we all grew up with, are based on that 50% average age of attainment. So they're mostly worded very vaguely, like your child might begin to roll over at 4 months. Look for them to start to sit up by 6 months. On average, kids start smiling by 4 months. So it was very vague. And that lent itself to a wait and see approach, because it was 100% warranted for a physician to say, hey, you know what, let's give it a few more weeks. Let's give it a few more months. Maybe it's fine, because it was an average. So the idea that the CDC has to make this more workable as a tool is to line up when 75% or more of children can do it with a well child visit age. So each of the checklists now correlate with that well visit age and have a streamlined number of milestones, each of which is 75% or more of kids can do it at this age. So what that means is if a child is missing one of the CDC milestones, it is an immediate red flag that the child needs to be further evaluated. You need to assess if that child needs to be referred. It's no longer a wait and see. This is at 75% or more of kids can do it at this age. So let's see what's going on, that the kiddo's not reaching that milestone. This change did result in some changes overall. A lot of repeated milestones were just taken out altogether. Vague ones were taken out. All of the milestones that are in there have at least one data point that lines up this age with the age of attainment and the well child visit age. And they also worked to make the milestones more clear. In terms of the differences in ages, you'll see differences from, it used to be the old milestone was at 4 months, baby starts to roll over. It's now 6 months, baby can roll over frontwards and backwards. So it made it much more specific as well to help parents know exactly what they're looking for. Same thing with the language was clarified to make sure we're really identifying what we think we're identifying. So an example of this would be at 18 months, instead of child explores on their own away from parent, was changed to the child explores but looks back to see where the parent is and checks in with parent while exploring. Those are they have very different qualities to them. So they really went through and tried to clarify and make sure that we were identifying what we thought we were identifying. They also completed cognitive testing with over 50 different families of different socioeconomic backgrounds, educational backgrounds, ethnic backgrounds, to make sure, again, that the milestones were clearly understood by families and we were identifying what we thought we were identifying. So as I mentioned, that final product now has just a really streamlined, very specific set of milestones where most kids can do this at this age. But they've also now included some open-ended questions to spur conversation between physician and parent, and for parent to think about too, to help them articulate any concerns that they may have going into the well visit. And then also some tips about how to really promote development and how to interact with your kiddo to help promote development. Some challenges, as I mentioned, they did line up every single milestone with normative data, but it was hard for them to find data actually. And it turned out a lot of our traditional milestones are tradition, but there wasn't a lot of actual evidence base for a lot of them. And in a lot of the validated screener tools, they point to each other as evidence base, but they don't themselves actually have an evidence base. So they are the CDC team that worked on this, calling for more research in this area so we can make sure that all of our milestones are based actually on a strong evidence base. It did, again, kind of end up with more streamlined milestones because they really were looking for these two specific criteria to be met. 75% or more kids can do it at that well child visit age. So some of the milestones were moved to a later age, about a third of them. And this resulted in a huge controversy that no one saw coming. So these were published in early 2022. And because some of the ages were changed, there was this huge eruption on social media that no one could have fathomed, which was the CDC has changed the milestones in order to mask developmental changes that occurred during the shutdown from COVID. So some of you may have heard this. We encourage you to ask about it. If you did, we'd like to talk to you more just to help answer any questions. But just so everyone knows, actually, this was a multi-year process of revision. All of the data review had been completed by 2019. The family testing had been completed in 2020. It was just the manuscript publication, review process, and all of that, and it was published in early February 2022. Again, the idea of changing the time frames was this idea of trying to make it an early identification tool that would prevent the wait and see approach and hopefully find more kids as early as possible. So it was not done on post-pandemic data. And in fact, we do not know yet about any, we don't have any information about that as of yet. So two other controversies that came up within this related was the milestones do not include crawling. And this was determined, they decided not to use crawling just because one of that 75% cutoff and the well visit age. Children start crawling at all different ages, and the quality of the crawling is very different. And there can be the army crawl, the rolling around, the scooting, traditional crawling. So the omission of crawling in the checklist was not to say that it wasn't important. It just didn't line up to those two criteria. And so they just didn't use it because it didn't fit the sense in the for the tool. So a lot of people in the OT world were concerned, and the physical therapy world were concerned that omitting crawling would omit thinking about crawling in terms of whether or not to refer. Again, the milestones are a family educational tool. It is not to replace your judgment as a physician and whether or not you are concerned. The next one was talking. This was the one that really created a lot of controversy and was really thought to be, the masking of the COVID changes. So the previous milestone had that 50% age of attainment of 24 months. At 24 months, kids should be able to say 50 words. The new milestone is now 30 months, which reflects the data that shows 75% or more of kids have 30 words, have 50 words by 30 months. The Speech Language Pathology Association, called ASHA, raised a lot of concerns about this change. They were concerned that if we're waiting to 30 months to refer to EI based on this question, then kids were going to miss a valuable window of early intervention. So again, this is a family education tool. If you see a child at 24 months that you're concerned about their abilities to speak. If you're concerned about their social communication, they're not, sharing interests with parents, they're not pointing, they're not gesturing, by all means, do not refer because of the Learn the Science Act early milestone guidance. But this was just the change to that 75% of kids are able to say 50 words at 30 months. It's just a reflection of the criteria that they're using as an early identification tool and to get parents to act when their child is not speaking. But please refer whenever you are concerned about a child's development. Do not wait based on the milestones. So I'm going to pass it over to Jean to talk about Learn the Science Act early in your practice.
Thanks, Cari. But before we do that, since that's a lot of information that I think you might have questions, does anyone have any questions or comments about particularly the changes in the milestones?
This is Barb. I just want to say, first of all, that I totally support what they did in terms of trying to get the evidence and also making it not at all a wait and see, that you automatically, if they're not meeting those milestones, then you need to refer. I will admit, and I'm not at all, I think this was done for COVID type thing, but I will say what I've found, because I teach residents in continuity clinic, they look at these CDC milestones and they think, oh, that's what the average person does. Now, obviously, as an attending, you can correct them, but I am a little concerned that when one puts something out like that, I guess I sort of feel it would have been better if they'd done this as the identification piece, but then kept the 50% as well, because I actually think that it's very easy for people to fall into the feeling of thinking this is what's average. And that, when I think about it, and obviously one needs to talk to families and stimulate them, but I think it's just really important. There are a lot of families, with lots of resources that are going to be really stimulating their kids anyway. Families with less resources who are really busy, are sort of at risk of thinking, oh, this is fine. They might be at the 26th percentile, but oh, it's fine. Whereas, obviously you'd like to stimulate your kid as much as possible. So I'm just saying, I think that that's an unexpected sort of fallout for this that we need to sort of work on.
Yes, I think even, having this forum now to help explain to providers that this is the intent, that it is that 75%. I think you're right. I think there is a lot of room for that confusion. I know the previous iteration had the 50% and then had red flags, and still they felt that was confusing, and I do think we haven't found the perfect, the secret sauce, if you will, and the perfect way to present these. But I think your concerns are valid, and we will definitely bring this to their attention. The intention is not to say this is the end all be all either. I think it's a process, right? And they are trying to figure out the best way to make these usable as early identification tools. So we will certainly bring that back to the group for consideration, because I hear what you're saying.
Yeah, I have conversations with residents about this all the time, correcting them.
Right.
So
that's important. Yeah, well, it's really important.
I actually have two questions, Cari and Jean. Number one is, I think, has there been any correlation between the new CDC milestones and the existing screening tools that we use? For example, the ASQ, because when a parent answers a question on the ASQ, and that's what I'm looking at as my screening tool, and it's saying at 9 months, here is what, I know it says starting to do, does the thing, or hasn't started, etc. Does that correlate to what the CDC milestones are telling the parent should happen at a 9-month visit as well? Are those things related? And then the second part of the sub part of that question is, I wonder like when EMRs, because I know our EMR, for example, has built in at 12 months, here are the milestones for the 12-month-olds. Now, what I don't know is if we created those and put them in those fields, or if it was already kind of like a bulk set. And if EMRs are, because whether we like it or not, a lot of this is like driven by what I look at on my screen and what I click and all those sorts of things. If that doesn't correlate with what the new recommendation from the CDC is around what a child should be doing at a certain age, I could see where there could be like some discordance there as well.
We have,
100
in our practice, we have actually updated the milestones. So
Okay.
since it changed, because
You
of
went in and moved it so that at 9 months, it said,
template, so we had the new guideline, the new developmental milestone. Yeah. So you have to double check and make sure that they are updated. in your-
great, okay.
And again, it's that 75%, you know, and I think that's so important that everybody really like have that very clear in their minds that it's the 75% or more cutoff, as to Barb's point. So I know they referenced like some of their normative data did come from like the ASQ, the MCHAT. I know that part of the problem was that a lot of those screener tools, like I said, did reference each other as evidence-based. And I am going to ask, because I think what you were asking is important. And I wonder if there's like a table that has been generated that has that information lined up. So, you know, at 9 months, the ASQ says this, Bright Future says this, et cetera, et cetera. I know that we just actually had our annual training, and the AAP provides our technical assistance. And they were talking about including like making this, as you said, in the EMR. I think your EMR, a lot of it's generated by Bright Futures and the AAP. So they were discussing that as like a next step, including that in there, and, you know, directing people to the app as well. So that is a work in progress, the EMR piece and the patient guidance.
Okay. All right, one of the other question I had was, and I'm making a note to follow Nadia's lead, and we probably can go into our EMR and manually like recreate each of the visits, like what the milestones that we want at those visits. So we'll look into that. The other question was, so if you, I think you showed the example of like the handouts of a 6-month-old one, and at the bottom it's like recommended things a parent could do or something like that.
Mhm.
Is that like, should I be giving that out at the 4-month visit and saying, okay, at the 6-month visit, the next visit, here is what you should be able to do, and here are some things to like get you to that? Or is it more like, you are now 6 months old, here are things you should do moving forward?
Do you know what? I think it's the latter, but let me double check on that, because actually you're the first person who has asked me about that.
Because I always wonder, like, there's all these things like to help you, if we really want to get ahead of things, right, and be preventative, it's like, okay, let's not wait for me to realize you're maybe a little bit behind in a couple of these things and then give you these tips. I should give you the tips before you even see those things, and kind of so that you can start incorporating them. But I think the tradition is usually we hand it out at the visit. The 6-month visit has the 6-month milestones, and like, you're like, they're like, oh yeah, I already know that. That's what they're doing. And you're like, okay, well.
Okay, right.
That
And
isn't
then,
the idea of using the app, like guiding them to use the app and look at it, maybe? Wouldn't that
Yeah.
be good?
right, I was going to suggest that, because the app does. I have my faux children set up in the
So do I.
app, so it'll send me prompts like, oh, you know, they'll want to do this, or you know,
Yeah.
don't forget to do this. Kids this age like to point at pictures and books. You know, they do have to turn their prompts on. Like, you do have to give permission for the prompts. So, but if they do, then it will send them little messages to
Okay.
remind the parents to do these little activities. So,
Okay.
Well, and this is Barb again, because I'm not on the phone, so I can't see this stuff. But, you know, to the point he's making, I would just, my own personal opinion is it should clearly be done at the 4-month visit, because, you know, like if you're, whatever we're dealing with, that's when over 75% of kids do this. Like, you're only, at the 6-month visit, you're only talking about sitting up. I mean, you're not even saying they sit up yet, you know, whereas
Right.
frankly, 50% do sit up. So you wouldn't want to be waiting
Right.
until
True,
that
true.
later age to be, that speaks to my point about my concern that some parents therefore will have this false belief that there's no need to stimulate to get these goals.
Right, got you. No, and I think, and that's kind of what Asha, I think their criticism was saying about the number of words at 24 to 30 months. That same idea of people thinking it's okay in that 50 to 80 percentile there, right? And maybe they should be doing more earlier. So it's a very, very good point. So we will bring these back and kind of just discuss it more with the group. And if we have some guidance to bring back, we will share that with Mark and Muge.
Awesome. Thank you.
Thanks.
Any other questions, you guys? I know it's a lot, so. Okay.
Okay, great.
Team, take it away.
All right, so, but you're going to advance the slides for me?
Yes, here we go.
Is that right? Okay,
Yes.
so you can go ahead and go to the next one. So I'm going to talk a little bit briefly about some of the resources. Cari gave you a good overview, so we won't spend too much time on this, but I wanted to spend a little more time on some of the resources that are available. Our big ask is to help you, to ask you to help spread the word to the families that you see about these resources, reminding you again that these are resources for parents to educate them about what to expect. And one of the things that's been found is that when a parent is more aware of what is expected, they're better prepared to have conversations, particularly if there are difficult conversations that have to be had about the child, what you're seeing when you're doing the actual screening and observation of the child. Next slide, please. So the app is really the premier resource at this point for the CDC. I think a lot of the issues that were discussed just now, there's more likely to be able to update the app and account for that. At this time, it's free for everybody. And it's available in English and Spanish. There is an adjustment that can be made if the baby was premature to adjust for the actual age of the child. And it does have a question. It has prompts about what you could do with your child to help with development of that. There are the reminders about well-child visits. And there's also even a section that allows you to summarize what they have observed in a format that could be emailed to the physician, pediatrician, or I hate it personally, but they could show you on their screen, on their phone, what they've been able to track and what they've observed. There's prompt questions, there's coaching, and there's sort of what to do what a parent should do if they are concerned about something. And the first step is always to talk to their doctor. Next slide, please. So that's the app. If you have does anyone have any questions about the app before we move on to the others? No. Okay. Great. So if we can move on. Another sort of premier popular resource for the Learn the Science campaign are the books. There are 3 books, one for infants, one for 2-year-olds, and one for 3-year-olds. They're available in English and Spanish. And what they do is the character in the book is demonstrating the milestones. And then at the bottom of the page on one side is a description of the milestone that at that age that child should be exhibiting. And on the other are some tips for what the parent can do to encourage the development of that milestone. So they come in English and Spanish. I thought I would just show, I don't know if it's going to show up so well here.
There you go. Well.
So they're available, limited copies are available for free. You can go onto the CDC website and order them. We can also, the files are also available, and you could print them and customize them to include your practice name on them and contact information if you'd like. And we can help you with accessing the files. We have worked with a printer or two in the area that we could connect you to as well, if that's something that you wanted to do. Okay. There are growth charts, also again in English and Spanish. And then there's posters, there's brochures. Some of the resources are actually available in about a dozen languages. All of the checklists are in languages including simplified Chinese, Arabic, French, Creole. So there, if you find that you are in need of a particular language, the website is a good place to go. We can help you navigate that. And then what we found is that across the country, different ambassadors have found a need for different languages. And so sometimes we can find another language translation that we could share with you as well. Next slide. So the thing that is that we most wanted to point out to you is that on the website there is a specific location for healthcare providers that has all of the resources that you would find most useful. So that link is in at the end of the presentation, but it highlights both what the AAP is. It's fairly integrated with the AAP website, so it includes the recommendations and resources and CME available through the AAP, as well as which particular resources might be most helpful for you in your practice. Next slide. And then there's even resources about if there is the child it does need to be referred. There are tip sheets for parents about what to do. And as you can see, on the right side of this slide, one of the first things is talk to your doctor. So you want to, make sure this might be something else that would be helpful for you to share with your families. Next slide. And so one last idea, it's great that the idea of building the milestones into your EMR is, was discussed, and that you're already doing it, Nadia, that Mark, you're considering it. I think that's great. One ask that we had, or one suggestion, was to see if you could put a link to the app in your after visit summary. That's a much less labor intensive, and at least it will begin to be something that you can promote, a way to promote it to the parents. And I think that's all of our slides. Okay, and then I'm going to turn it back over. Unless people have questions about specific resources, we'll go ahead and I'll turn it back to Cari.
You are sending those slides at the end of the.
I think that's right. Okay, yes. Okay.
Okay, thanks.
Okay, so now going back to our 4 steps of early identification, we're going to talk a little bit more about step 3, referral for services, and step 4, actually receiving your early intervention resources. So we thought it just might be helpful to review some of the referral information for some of the early intervention resources in Illinois. So first and foremost, the ICAP website does have an early intervention website or web page that can help you navigate referral information and help you just find different resources and information that you may be looking for. We want to call your attention to the early intervention standard referral form and release of information, and I've linked it here at the bottom. So when you receive the slides, you can use this and click on this. There is a standard referral form that you can send over to the early intervention office. On the back of it, it has the release of information form. So when you make a referral, if you can go ahead and have the family sign that ROI, that will be really helpful for closing the loop for you all as providers. Something we have heard a lot from physicians is that they make the referral to early intervention and then they never hear anything again. And the family may say, oh, we never were contacted, we don't know. But it's hard for the physicians to get information about what actually happened with the referral. If you have the family sign the ROI, early intervention is able to communicate with you what happened, because the process right now is that they are allowed to follow up with you until they actually communicate with the family. Once they've spoken to the family, they have to have that ROI to come back to you as to share information with you as a physician. which is a little bit frustrating. We understand. But what that means is if the family rejects services or doesn't follow through with the evaluation appointment or what have you, EI is not able to share that information with you. So if you complete that ROI when you first make that referral and send it along with the referral, then that can help close the loop and hopefully help the process along. We do want everyone to know that you can refer when you make that referral in the referral form. You can actually request for a medical diagnostic visit to be done in EI as part of your preliminary referral. So if you're really concerned about autism or some other big delay, you can actually make that request on that referral form. We do ask that if you're comfortable, go ahead and use the word autism with the family. We understand some families are not there yet. They're not ready to hear those words, and therefore you're not ready as the provider to kind of bring that up as a possibility. But if it's something that you're concerned about, we ask that you include on that referral form what you're seeing that may indicate autism or your other concerns. So describing as specifically as possible, like difficulty with social communication, repetitive movements, specific interests, those things that kind of help guide the person who gets that intake form, like what are we concerned about? So we just want to make sure everybody does know that. And again, that autism can be reliably diagnosed as early as 24 months. So if you are concerned for that, they can go ahead and start services right away and even do a diagnosis before the 3rd birthday. And we can make sure we get them into the right school district services by their 3rd birthday. Again, in terms of free materials for you all in your practices, look what I can do from Early Intervention does provide lots of free promotional materials. So you can get brochures to pass out to families if you make the early intervention referral. You can just have them in your office so people know that early intervention exists. They have refrigerator magnets and all sorts of things. So you can go to the website and get that stuff delivered to your practice for free. Just some further background information so everyone knows about early intervention in Illinois. Early intervention services are provided via local, what we call CFC offices for short, which stands for the Child and Family Connections Office. As you can see, they're broken up by groups of counties. And so they are the local service coordinator and provider for early intervention services. One of the reasons I think families don't follow through with the referrals, they don't understand what early intervention is. There is a lot of worry about having people from the state come into their home. So I think it's clarifying that these are therapists and that they're professional therapists. These people are all licensed outside of early intervention. So they are OT, speech, all qualified, master's degree, credentialed providers. I think that's something that also gets confused along the way, that these maybe are not, fully credentialed professionals. So I think it's important for everyone to know that these are fully credentialed therapists who are coming to the home, kind of talk to the parents about their concerns about having the therapist, what the therapist means. I think it's super important to tell families how common developmental delays are and really help normalize it. I think there's still a lot of stigma and a lot of families that are concerned about reaching out for help. So whatever we can do to normalize that need for that little extra boost early on can be really helpful. In early intervention, families are also able to access social work and get plugged into other resources that may be helpful. And they are also assisted in starting preschool at 3 with their full suite of needed services. So we're going to talk a little bit about, there are some delays in early intervention, as everyone knows, but it's good to keep that referral going and open with the idea of hopefully the child does get called up and we can have the social work and preschool transition better coordinated with EI. Another important thing for families to know is that these therapists can come see their children in daycare. It can be a lot of parents decide not to follow through with an early intervention referral because they both work and they don't know how to make it work for the therapist to come to their home. So it's important for them to know that the therapist can go to daycares in order to provide the services. Early intervention does have a staffing concern right now. They're working hard to address that, but in the meantime, I know that many of you know some of the therapies and starting of services has been delayed for many families. So in the meantime, what can you do as a physician? You can go ahead, and if the family is able to access private speech, OT, or physical therapy, and they need that, go ahead and make those referrals. If you're noticing other concerns, sleep problems, GI, picky eating, if you're concerned about developmental delay, go ahead and make that referral to genetics and audiology. I forgot that one, it's not on here. Go ahead and make that referral for audiology. Some families may qualify for a home visiting program, so you could always look at seeing if you can refer to home visiting. And then just children with developmental delays are at a much higher risk of drowning and other accidental injury. So it's always good to kind of assess the family situation and see how the kid, if the kid is prone to eloping, running away, different issues, and help the family with some safety concerns. Swim classes are a wonderful idea to help prevent drowning. And if you're interested, you can message me, and I have a list of developmentally delayed friendly swim classes that I can share with people. For early intervention, the Early Intervention Clearinghouse is a wonderful website that's family facing, that has a lot of information about what early intervention is. You can access family navigators through this website, and the family navigators can help families feel more comfortable with early intervention. There are a lot of great resources like a toy library where families can actually check out toys to help promote their child's development. And they're pretty lenient about this toy library, so it is a great resource. There are a lot of resources available as well to help families get connected into internet, have tablets so they can do virtual visits, which is helpful in more in areas where there aren't a lot of providers. Parents have concerns about doing therapy appointments virtually, but early intervention is a parent coaching model. So actually, it has been shown that they're doing a pretty great job of coaching parents and how they can help promote, their child's development in speech, the sensory regulation with OT. So please encourage families to consider virtual appointments if possible. For those kids who are older than 3, they no longer qualify for early intervention. So we look to the school for services for them. In the Chicago area, those are done at Child Find events around town. There's a link at the end in our helpful link section for the Child Find dates here in Chicago. So the families go, they do a quick evaluation, and they're kind of put on the list for CPS. If you are outside of CPS, the family needs to call the school district and request a special education evaluation. And they do need to say that they'd like a special education evaluation. We have heard many stories that if you don't specifically request that, the school district doesn't necessarily offer that information. So families will say, well, I called the school and they didn't do anything. So they have to specifically request that. And if the ball does not immediately start rolling with that phone call, then the family should make that request in writing. Something you can do as a physician is offer a generic letter that states you have concerns and you'd like the child to be evaluated for an IEP, which is the Individualized Education Plan. You can also write it as a joint letter that is from the parents, signed by the parents and signed by you, if you're comfortable with that, but that is an idea that you can do. English as a second language also is a reason that kids can start preschool at 3. Oh, I just saw we're getting really close to the end. Okay, so really fast, just 2 myths. Children do not need to be toilet trained to attend school with an IEP. That's a big concern that parents have. And also parents can ask for transportation to be included in their IEP so that their child can get picked up from daycare and brought back to daycare so they are able to participate in half-day programs that the school might offer. And that will allow children to access all those services during the day with the school district. We have included these links here for some family supports to help them get the services that their child needs. And we have those included in the helpful links. Just other family navigators. Equipped for Equality is a free legal advocacy group that helps kids with developmental disabilities get the services that they need in school. And then we just have some links for some other resources that are really helpful for families with disabilities to get help. Illinois Cares for Kids is actually for all kids, for everyone, and it has everything for how do you get your child's insurance to how do I get daycare, what are the rules around daycare, how do I get WIC, how do I get my kids started at school. So that is a great resource that everyone should be aware of. And that's it. Are there any questions? I know that was a long presentation.
This is Barb. I'm just interested, who does the medical diagnostics if you request it?
So it depends on where you are.
Okay.
There are a number of sites around Illinois. Early intervention requires that a developmental pediatrician be on the team. Usually they're multidisciplinary teams that usually have the developmental pediatrician, usually a speech therapist, maybe a social worker or a psychologist, a physical therapist, or a occupational therapist, and usually a developmental therapist. So it's usually a lot of eyes on the child. But the one requirement from EI I know is that it has to be a developmental pediatrician on the team as well.
Or they find them.
Do they provide eating therapy for kids that have problems with eating? I mean, I know
I believe so, and just specify on that because they have speech therapists. So they should, not every speech therapist is well versed in feeding therapies, but if you specifically state that feeding is the issue, then hopefully they should be able to assign someone with that background.
Right. Thank you so much, Cari and Jean. I'm going to go ahead and stop our recording.